Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I have the distinct pleasure today to be talking with two individuals who are going to be talking about holistic housing methods and the implications for healthcare. With me this morning is Mr. John Romanin, who is with an organization called LetUsBuild.org, and Dr. Pat Tokarz, a family physician in Northern Virginia, who's had a career searching for how best to deliver holistic health care. Gentlemen, good morning, and thanks for joining with me.
Good morning.
Good morning.
So, John, could we lead off with you? Could you tell us that you have a passion for building affordable housing for the working class and the poor, and you've started this organization called LetUsBuild.org. Could you talk a little bit about that?
Sure. Yes, I'm president of the the host organization is the Housing Crisis Solutions Coalition, which is a coalition made up of the modular industry and American renters as the customer. We started it 2 years ago in response to our experience in the affordable housing space, where we encountered severe scarcity of product in Phoenix, Arizona, whereas our demand was extraordinary. We were able to place maybe one or two applicants of every 10. And that problem is discussed as the housing supply crisis. And as a result of that, you see headlines and reviews pretty consistently that rental rates throughout the country continue to increase significantly. So what we're dealing with here is a closed market where the supply source is almost exclusively related to the HUD affordable housing sector space, which is the primary cause of the supply crisis. And as a result of that, 60% of all renters really don't have a choice other than to deal with the extraordinary increase in rental, which averages about $1,500 a month as a median throughout the country. So we're building to deliver $650 to $900 one-bedroom units using our new modular building technology and our new operating models.
So, John, in an earlier conversation, you told me that less than 5% of construction is around affordable housing. So, most of the housing that's being built is really not affordable for the working class and the poor?
That's correct, and I'll emphasize again, the metrics surrounding that affects 60% of all American renters in the aggregate, which also translates into between 40 and 50% of the U.S. labor force. And using Phoenix again as an example, where we call it our test bed in the desert, the metrics are that for current planned and projected multifamily development, over 95% of that market is represented by new Class A product. Less than 5% can be considered quote unquote truly affordable product that can deliver the solution to meet the budgets of that 60% of all renters, and certainly in this case in Phoenix. As a result of that, for example, analysis and reports would put Phoenix as the third worst city in the country in terms of affordable housing.
So when we talked last, John, you mentioned that there were two major dimensions or factors that influence the cost. The one is the construction cost, and you've already alluded to the modular housing. Can you speak a little bit to how is the modular prefab construction method that you use, how are you able to produce a unit at lower cost?
I think it's easiest to refer to factory-built housing or industrialized production of housing product, which is increasing rapidly in terms of production capacity. The issue there is that with the efficiencies of industrialized production and factory work and delivery to site for on-site installation and completion, we can. There are several variables that allow us to deliver product at a reduced cost. We have to keep in mind that what we concentrate on is what the market or the customer values and what that customer can afford to pay in rent. After reviewing all of that metric, what we realized is that we have to build in this example, one-bedroom product in the range of $600 to $650 to maybe $700 a month. Keeping in mind the aggregate average median rent throughout the country now is at $1,500. So we're literally required, based on our mission, to build at half the cost of the rest of the multifamily delivery of product. So by doing so, we've really thrown out the systems in traditional building and in investment to build product and deliver product. So we had to determine the feasibility of doing that. The only way to do that is through the efficiencies of modular industrialized production and off-site construction or new modern methods of construction. So management is key in terms of really applying the most important advantage that we have with this new building technology, and that is one, speed to market, speed to completion, and also the issue related to the time value of money. And so by really replacing our operating models to remove and redirect property management that's fixated on real property, our management operating models focus and fixate on real people. By doing that and successfully deploying that operating model, we've discovered that we can see very important new ancillary income as a result of that focus on qualitative and behavioral management of the tenant base. And as a result of that, we've discovered new opportunities in terms of delivery of service in a competitive market. And clearly DPC, in one, first accomplishing the delivery of safe, stable, and affordable housing to achieve that, to meet the needs of the 60% of the renter base, we've developed other social service platforms to compete with the default social safety net, or what we refer to as a dependency net, that's exclusively delivered by the HUD affordable housing sector and nonprofit sector. So we're introducing.
So John,
yeah.
If I can interrupt for a minute, I want to go back to the issue of direct primary care. So one of the things you said in our last conversation is that one of the drivers that increases the monthly rental fee is the occupancy rate within the unit. And you mentioned that one of the biggest issues affecting people's ability to stay within and make their monthly rental payment is their health. If they are sick, if they lose their job, then obviously they are out of the unit. And you're bringing in direct primary care so that the folks have access to something that can help them stay healthy and keep their job. Is that accurate? And could you talk about that a little bit?
Well, it is absolutely, and this gets back to my original discussions with Dr. Tokarz, and that is we've discovered very significant parallels between the housing supply crisis and the affordable housing crisis and the healthcare crisis, and it all drums down to cost and obviously access. So what has happened is that in many cases, one of the reasons that we find tenants coming to our services, they've experienced some level of trauma. In fact, we've quantified that. We have built our operating model to be able to manage 3.x levels of trauma, life trauma issues that each tenant will encounter every year. So for the same reason, our focus is on the delivery of safe, stable housing. That applies as well to healthcare delivery, which is extraordinary in terms of the quality of healthcare delivery that we've discovered through the DPC model as it exists today, and how that impacts in such a very positive manner on the status of each of our tenants, who, by the way, average income range is $18,500 a year up to $87,000 a year. So depending on the profile, the financial profile, and the life cycle status of the tenant, by offering this combined service of safe, stable housing at the rates I described earlier, which is clearly mandated, but combining the healthcare creates a stable tenancy base that just adds to what is typical of the affordable housing space, and that when a tenant does secure safe, stable housing, the tendency there is overwhelmingly to develop a stable rent roll that translates into investment returns. So much of what we're discussing drops to the bottom line, and quite frankly, we're discovering that by combining the two primary budgetary challenges that so many millions of American renters encounter, it is just clearly seriously distortive in terms of the benefits to that 60% of all American renters we define.
Let me interrupt here and just emphasize that it's very fascinating to see the parallels between what John's coalition is trying to do in terms of creating safe and stable housing by looking at the bigger holistic picture and going to TenantCentric Solutions, basically providing the tools for tenants to become more successful tenants. In other words, more self-care in terms of how they can stay in a stable, safe housing situation longer by incorporating DPC, whose goal is to create better skills of self-care among its patients by its very nature. But John is also looking at access to basic financial planning and financial management skills for the tenants, because another cause of difficulty with paying their rent is lack of skill and experience in managing finances, and many other skills which tenants need in order to continue to be successful. It's also parallel, Larry, with what we're seeing with DPC having a positive synergistic working relationship with employers by providing improved access and improved higher quality of primary care to employees, resulting in decreased absenteeism, increased productivity, and turning out to be a very good investment for employers who work with DPC practices to provide DPC care to employees. I was just fascinated that it's equally financially advisable for landlords, if you will, to provide these services to their tenants, not only is it the right thing to do, but it actually makes economic sense. And that's what I just was so excited about once John and I started talking about the possibilities of looking at the holistic solutions for both healthcare and housing.
Yeah, yeah, go ahead, Larry.
Renters are single, their mom's single head of household with kids. And I'm wondering, can you comment on how people are responding? And it's my understanding that the monthly rental fee that you're charging includes also their membership into the direct primary care practice. So how are people responding to all that?
Well, first of all, as with many of our models at this point, believability becomes a primary issue, but that applies to the industry perception of affordable housing that has been a closed market and supported by the federal government and typical private-public partnerships from investment all the way through management. So what we're offering here is all private sector-based funded and managed properties. And the response is overwhelming, not only when you can meet the needs and the financial requirements for these individuals, but when in fact you add one more platform, for example, that provides that holistic support that involves as well just great direct access to your family doctor, for example, and knowing in our case, tenancy base is upwards of half occupied by single moms and one or two children. They find it extraordinary. And what's really important at this point, I do want to point this out, is that we've gone through the feasibility and the metrics involved in delivering this. And when we consider it on an investment basis and the return on that investment and that asset, what we've done is that we've pivoted, and by focusing on the individual, we treat our tenants as the underlying asset in that investment equation. And as a result of that, what you have are the periphery, direct and periphery advantages of an incredibly stable tenancy base when we are delivering the concierge services that involve the financial debt management support, all private sector based, combined with the quality of care that DPC practitioners can deliver is just extraordinary for these individuals. I will just give some math on this. The affordable housing space is a closed market. The only development of truly affordable housing is controlled by the HUD affordable housing sector and the nonprofit sector. It's one of the reasons and primary reason we have a supply crisis. For example, the math on a Section 8 voucher recipient in Phoenix, Arizona is the fair market rate defined by HUD at $868 a month. That means that mother with one child who requires support, she'll pay 30% of her rent. The HUD voucher system will match for private landlord occupancy up to $868, keeping in mind that the average cost for a one-bedroom in the market in Phoenix is over $1,000 a month, so we're pretty close to that. If we're building and delivering product at $650 a month, and we're delivering DPC care at, let's say in round numbers, $100 a month, you can see that the distortive reference I made earlier, we're actually delivering the extraordinary opportunity for that mother with children at $750 a month, which is significantly less than the HUD 868 voucher allowance. So it is truly distortive and really addresses a critical concern for just millions and millions of American renters. So we're in that phase now where we've defined the feasibility. There are issues involved. We want to make certain that legally in that particular scenario. And by the way, all of our tenants are working individuals and families. So we do come in with Section 8. We invite that. It's just a management question, and our tenant-centric management systems manage those individuals well by bringing in these two primary costs, and the overhead for each individual tenant is extraordinary. So you can see, just based on that math, the impact can be just incredible in terms of quantitative issues with regard to our investment asset properties and that underlying asset. And the quality of life is improved dramatically. Hello?
Larry, I think it's also worthwhile observing that by actually looking at the needs of tenants, and once again, what I learned by working with John is affordable housing affects such a huge segment of the U.S. Population. It results in average people with well-paying jobs, policemen, teachers, city employees, having to live 2 and sometimes 3 hours away from their job, which contributes to the cost and ecological cost of long commutes and time away from family. It goes on and on. When you can get housing that city employees can afford close to where they work in a city, it has dramatic trickle-down effects, if you will, throughout the whole community. And I think the realization among healthcare workers that you can't just provide medical care and expect good outcomes. You have to look at the holistic picture of what's affecting the health of the population. And the big thrust now is, you really want to have an impact on people's health, you have to get involved in community building. You have to understand the actual needs of the individuals in the community. But one of the biggest needs of individuals we find in healthcare is the need to actually be part of a community. In other words, the isolation that results from long commutes, from the frustration of time away from family, frustration of feeling like you can't afford to live like other people live. I think the implications for improving community building, having the tenants, the patients, the people actually contributing to these solutions. In other words, each of these housing situations will have a community center as well as a healthcare center to encourage interaction and encourage community building, try to rebuild the sort of the village concept that unfortunately the automobile and current economic situations have kind of destroyed for most of us. I think the synergistic relationship between looking at holistic solutions for housing and for health, including skills, self-care skills and financial management as well as health management are really pretty exciting, and why I think this will be one of the more rewarding areas to be involved in for both builders, healthcare workers, and the people we all want to serve. So, John, I applaud you for your far-reaching vision And as I told Larry, this is another example of overnight success. It's only taken 20 plus years of looking at the problem to try to figure out a market-based solution. And Larry and I have been doing the same thing in healthcare
Right.
for the last 40 years. So it's great to know we're on the verge of our overnight success.
Well, yeah. No, so that begs for more cooperation between the two coalitions. One of the things we'd like to propose, we're taking on the status quo in what we call our mapped modular programs and building initiatives. And Larry, for example, in Phoenix, we're building 600 units as a first phase of development of the product that we're defining here at the rates that we've described. We will also be installing tenancy support centers that will include DPC facility, which essentially will be located within that modular model affordable community. So we will be building these model communities across the country, and the benchmarks are being established in Phoenix. So clearly, by organizing and creating these new operating paradigms to address this end of the market that has been severely neglected to this date, primarily because of the inability of traditional solutions that have been the sum total of all affordable housing solutions. By introducing these new products and services, we expect to see just some incredible response from political leaders that we're working with, as well as policymakers, and adjusting the process that have existed as barriers to building in the past. By coming in with our private funding, what we're also doing, by the way, and this is what we're recommending on a policy basis, is that we go through what we refer to as a cost fungibility, with tightening budgets that you hear about pretty consistently, by our private funding sourcing and delivering this cost-effective solution set. We're freeing up money for what we think and believe the private-public partnership should concentrate on, and that is special needs housing and addressing the severe needs of that part of our population, which in percentage terms we'll say is between 10 and 15% of the market that they're trying to address now. So we're addressing the 80% of the market with private sector solutions, as we've described, partly of which we described during this conversation, and let the government and the tight budgets focus on those homeless veterans, the special needs individuals who really require more support. And by doing so, we're securing tremendous cooperation by political leaders as well as policymakers. And with that, then, we expect to be able to achieve our mission, which is to help resolve the affordable housing supply crisis. So,
John, I need to interrupt because we're running out of time, and I just want to thank you very much for your work, and thank you for your willingness to join with us and share this. Pat, thanks very much for your vision, bringing us all together.